Good afternoon, everybody. Thanks for coming to this special lecture. As you know, we do Dean's Lectures for two reasons. One is when people get appointed or promoted to professor, and the second is when we have either a visitor or one of our faculties that has doing really important work and I think it needs broader exposure throughout the school community. And I have the good fortune of meeting with Bruce Lee a lot and hearing about his work. And I wanted to offer our school community an opportunity to understand more about what he does. So I'm not going to do a long introduction, but a relatively short one. And Bruce came to us in 2013 as an associate professor and was recruited to head up operations research in the International Vaccine Access Center. And was doing that, and then a year later took over leadership of the Global Obesity Prevention Center and a large U54 grant from the NICHD on obesity prevention in children. And before coming here, he was associate professor at Pitt, and we were happy to recruit him away from Don Burke, and he was in the medicine and biomedical informatics there. He's had a lot of experience over his career, so I'm not going to go through all of them, but he's worked in both industry and academia. He was a senior manager at Quintiles. He was led a number of research teams there. He worked in biotechnology equity research at Montgomery Securities, and he co-founded a biotechnology bioinformatics program. He's worked with basically every global health / vaccine policy or research group and every government agency that deals with both vaccines and bioterrorism. He's authored over 185 scientific publications, and he's an associate editor of the journal Vaccine. He contributes to Forbes magazine, and he's deputy editor at PLOS, Neglected Tropical Diseases. He earned his BA from Harvard University, and then went to medical school at Harvard Medical School, and then eventually got his MBA at Stanford. He completed a radiology in residency. A residency in radiology and a residency in internal medicine, and he was a research fellow at Penn. So he's done a lot of things and an incredibly capable person. We're so happy to have him on the faculty. So please join me in welcoming Bruce to talk about Virtual Baltimore.
Thank you, Dean Clagg, and appreciate the opportunity to talk to all of you, and thanks for joining. So what I'll be talking about is the use of computational modeling, specifically computational systems modeling, to help better understand and address many different public health and global health issues. So this is a methodology or an approach which has transformed many other industries and professions, and it's something that we're on the verge of transforming public health, global health, and medicine. So I'm going to give you some examples and explain what I mean by computational modeling. So first of all, I want to acknowledge our many different sponsors who have been supporting our work. It's great that they're recognizing the importance of computational modeling. It ranges from the NICHD, as Dean Clagg mentioned, as well as the National Heart, Lung, and Blood Institute, the Bill and Melinda Gates Foundation, Laureate Sports for Good Foundation, as well as the Dean's Office has been very supportive. They've provided pilot funds for our Global Obesity Prevention Center. So this is a quick overview, but what I'll be talking about, first of all, I'll talk about complex systems and computational modeling, what I mean by that. Give you some examples of computational modeling that we've used for communicable diseases. As I'll mention, the advent of computational modeling in public health really started in infectious diseases. I'll explain that for a bit. And then talk about our Virtual Baltimore work and how that might be applicable to different types of non-communicable diseases. And then mention our GOPC as well. So what do I mean when I talk about system? Well, system basically is everything. A system is what we are. We're all individual systems. We have organs and blood and all these things that move within ourselves. And also we sit within systems. So as much as we'd like to think that we're independent thinkers and we don't need anyone else, we actually need each other. And we need our environment as well. So we interact amongst our environment, amongst our peers, our friends, our family members, as well as these economic environmental systems. So it's important to remember that if something in the system is perturbed or changed, we're all affected. So if you really want to address public health issues or global health issues, you have to understand the system and understand the ramifications of every decision and every action. So what's the danger of not using a systems approach, meaning not realizing that these are systems that we're tinkering with? Well, first of all, you come up with band-aids rather than solutions. So you might find a temporary solution, you might cover it up, you say, oh great, that looks fine, we can move on to other things. But the problem will then resurface its ugly head ultimately, and these solutions, quote unquote, are unsustainable. You also tend to miss secondary and tertiary effects, and that can be positive effects as well as negative effects. So when it comes to negative effects, you can actually have unintended consequences, meaning you can be very well-meaning and you can hope that you try to improve a situation, but there are many examples in public health where very well-meaning efforts actually work in reverse. So ultimately you have these negative consequences that can actually be worse than initially implementing the solution. On the other side, you can actually miss positive effects. So there's probably been many situations where you've been involved in a program or a policy that's had some positive effect, but you're actually missing the broader positive impact that that policy or intervention may have. So in many ways, you're underselling what you're doing. So say you make an improvement in a public health program. If you think about it, that helps improve people's lives, that can help bring about positive economic impact, positive social impact. It can improve people's lives in generations to follow. And then you're missing those reverberating effects. So when you're not addressing the system or thinking about the system, you can actually be underselling what you're doing. And finally, if you don't really understand the system, it's almost like throwing something into the ocean. You say, okay, let's see if this happens. Let's toss this policy or intervention into the ocean. Let's see if we have an effect. Say, oops, didn't have an effect, let's try something else. So you can waste a lot of time, effort, resources from this trial and error. So it's really helpful to really plan strategically and understand the system. So all of this calls for a need for more of a systems approach. So as I mentioned, everything is a complex system. I challenge all of you to come up with something that's not a complex system, and I'll ultimately, I'm pretty sure I'll be able to convince you that it actually is a complex system. So we've got transportation, manufacturing, financial systems, et cetera. Even sports is a very complex system. So one of the ways of understanding these complex systems is to use computational modeling. So when I tell people that I'm a modeler, I emphasize that it's not this type of modeling, it's actually this type of modeling. So also when I tell people that I'm a modeler, they look at my clothes and what I'm wearing, they're like, you've got no fashion sense, you're not a modeler. So it's really this type. So what we're trying to do is we're taking situations, processes, systems, decisions, what have you, and we're creating a representation in a computer program of each or any of these. So when I say, okay, we're going to be doing some modeling, the other thing that people think of is, oh, this is some type of arcane science, or we've got these wizard's hats and we disappear into a cave for about 7 months and emerge with an answer, say your answer is 7, and here's the answer, and see you later. But modeling is actually something that we do quite frequently. So I like to ask folks, this audience is a little too large to ask individuals, but I'd like to ask folks, when's the last time you modeled? And people always usually give an answer, oh, I modeled 7 years ago. I'm like, wrong. 2 days ago, oh, wrong. You just modeled when I asked you that question, meaning that you essentially model constantly throughout the entire day. So whenever you're faced with a question or a decision or you're evaluating a situation, you're actually modeling it in your head. So we all have these mental models that start off when we're born. These mental models are pretty underdeveloped. And as we acquire experience, as we acquire an understanding of what's happening in the world, we're actually building these mental models in our head. So when you talk about instinct, when you talk about reactions to things, that's actually your mental models. So if you have a couple decades of experience with something, you have built up a mental model, so that works very quickly. So you think of that as a reaction and instinct. It's actually a model working. So what we're trying to do with computational models is take what's happening in each of our heads, our understanding, and putting it on a table or putting it in a computer so that everyone can see what's going on. And it can be helpful not only for everyone else to see what you're thinking or your conceptualization of the system, but it's helpful for yourself as well. So as an exercise, look back at some of your major decisions or even minor decisions and ask yourself, how did I actually come up with that decision? You'd be quite surprised because many times we think, oh, I made that decision for this reason. But if you trace it back, you find that there are all these factors, all these relationships, all these considerations that you didn't really quite think of that you accounted for in your mental model, correctly or incorrectly. I also want to emphasize that modeling is not something that's going to take over other types of studies. We call this the Skynet concern. So are all of you familiar with Skynet? It's the computer program that's supposed to take over the world, in Terminator, maybe about decades from now, or that might be accelerated, who knows. But the concern that many people have when you talk about computational modeling is like, is this going to replace human decision making? Or is this going to replace other types of studies? No, I want to allay all of your concerns or fears. Modeling is actually there to help other studies. It's actually there to help facilitate decision making. Ultimately, humans have to make decisions. So we're not going to get around that. But essentially, modeling can serve as a bridge to translation and really can enhance many other things that we do. So for instance, if you have a need or an idea and you want to plan a study or you want to plan an approach to addressing that need or idea, you can build a computational model to help plan a retrospective study or a prospective study. Another example is if you get a retrospective study and you don't quite have the whole amount of data available, or you have data from a particular location like Los Angeles and you want to say, well, what happens if it applies to New York or Madrid or Rome or Beijing, et cetera. Or if you don't have the right granularity of data. So say you might have data for groups of people, but not for individuals. Well, computational modeling can help bridge that gap. You can create a model of New York, or you can create a model of Mexico City or other places like that. And also the same thing is true with prospective studies. You have all these limitations as well. Prospective studies can be very expensive if you don't plan it correctly. You can also have ethical and legal issues. This is one of the reasons why computational modeling first became popular in infectious diseases. So if you think about it, if you want to understand the spread of an epidemic, you can't really do a clinical trial where you say, okay, I'm going to release a pathogen in society and see what happens. First of all, that would not pass most IRBs, and you could probably do it once. So for ethical and legal issues, it can be helpful to actually do a computational model first to really understand what's happening there. And then in each of these situations, you can translate retrospective and prospective study findings to policy and practice. So you might have findings from individual studies, and you can see what happens if I apply it as a certain policy or intervention. The other thing I want to emphasize is people may think that modeling is, okay, we build a model and then we're done. And I want to emphasize that modeling is a living, breathing, iterative process. So I like to use this diagram to show that how modeling interfaces with other disciplines and decision-making as well. So we convene multidisciplinary teams because systems are not single disciplines. So problems don't say, oh, I'm an epidemiological problem, or I'm a nutrition problem. Well, some of them might be nutrition problems. They tend to be cut across disciplines. So it's important to get different people involved. You can create mathematical and computational models to really represent these systems, and then so that everyone can see what the system looks like. That can help elucidate important factors in relationships. It can help guide and prioritize data collection. So once you have a model there, you can run different scenarios and say, what happens if I know this parameter or have this piece of information? How does that change things? So you can actually rank, okay, let's say this data is most important, this data is maybe not so important. You can use the models to test different policies and interventions. And then that informs stakeholders who are either designing studies or actually implementing policies and interventions. You then implement the interventions or policies. That gives you more data and results. Then you can update the model. And then this moves in a cycle constantly. This is the same thing that occurs in our mental models. We're constantly updating our mental models from experience. So similarly, we want to use an iterative process when we're developing models. So you don't have to come up with the perfect model at the beginning. Essentially, you have to come up with a framework, and then ultimately you move closer and closer towards what you want, towards your goal. Okay, so let me give you some quick examples of how we've used computational modelings previously when working with policymakers and decision makers. These are just a few examples. I picked a few exemplars. And again, these have been focused on communicable diseases. So first is influenza, or spread of flu. During the 2009 influenza pandemic, our team members were embedded in Health and Human Services using computational modeling to help with the national response. So addressing questions such as, should schools be closed? What should we do about vaccines? What's the impact of the delayed vaccine production? Because as you know, it took a while to produce vaccines and vaccine distribution. Questions such as those. So we developed models using a synthetic population in the United States. And what do I mean by synthetic population? Well, essentially taking, working with our colleagues at RTI, they developed a synthetic population using US Census data. So you take these different census files and you recreate a whole population of computational agents. Now, computational agents are just like virtual people. They have all these different characteristics like a gender, age, socioeconomic status, different habits, what have you. And so each of us, in theory, was represented by a computational agent. So then these computational agents were assigned to different households, and this is geospatially explicit. So if you have a certain household, that might have 2 computational agents. There are parents and a bunch of computational agent kids running around, and created this US population. And then if we want to create a model of a particular region, then we can extract the synthetic population from that region. So for instance, we can extract the DC metro region, which is 5 MSAs, which includes Baltimore. So this visualization shows what happens if you have the flu, well, not you particularly, but the flu spreads within a region. And this visualization shows that as you get more and more people within different census tracts getting the flu, it gets redder and redder, and eventually it all goes away. So this is just a representation of our DC metro area flu model. With that, you can ask questions such as, if I have a limited supply of vaccines, who should get those vaccines first? So we explored that in a study that was published in Health Affairs entitled The Benefits to All of Ensuring Equal and Timely Access to Influenza Vaccines in Poor Communities. So what we did here is we said, okay, what happens if you have a limited number of vaccines? Where should it go? Should it go to high-income locations, low-income, middle-income, or some mix of those? So essentially what we did is we want to determine, is there altruism that can result from utilitarianism? Meaning, if you want to try to do something which can benefit as many different people as possible, then can it actually have altruistic effects? So I'm not going to go through this in detail, but I just want to show you that we took limited number of vaccines, like what happens if you only have 200,000 doses, or 400,000, or 700,000. What happens if we allocate it to the highest income counties versus lowest income counties? The punchline with this is if you give it to the lowest income counties first, that benefits many more people and also benefits high income counties, meaning that you're actually having these secondary effects. Now, if you think about it, low income counties have high population density, so there's lots of mixing. So the flu can be transmitted quite readily amongst people who have high population density. And then many people in low-income counties travel to high-income counties for work. So they basically act as super spreaders. You don't see the reverse. You don't see people traveling from high-income counties to low-income counties as much for work. So essentially, if you're targeting lower-income counties, you're targeting super spreaders, so you benefit everyone. We also look at what's the impact of delaying vaccination to lower income populations, and this shows what happens if there's a 30-day delay, 20-day delay, 10-day delay, and then no delay. This is the epidemic curve. Essentially, the poorest populations are the key in terms of saving, vaccinating is the key in terms of saving as many, preventing as many flu cases as possible. Again, not just in the low-income neighborhoods, but in the high-income neighborhoods as well. So again, this shows the benefits, and this is another scenario as well, the benefits of vaccinating lower income people first. It benefits high-income counties as well, or high-income populations. The second example is our Raya modeling. Raya stands for Regional Healthcare Ecosystem Analyst. One of the keys when we were developing modeling projects, one of the most important things is coming up with a good name. So Raya, as you know, is the deity of flow. It's the Greek deity of flow. But this is basically a computational tool that can create these large-scale agent-based simulations of entire health systems. So representing all the hospitals, nursing homes, healthcare facilities in a region, as well as all the patients moving amongst the different communities in and out of the different healthcare facilities. So this can serve as a virtual laboratory. We initially used this to study the impact of different healthcare-associated infections and their spread and different prevention and control measures. So we used as an exemplar, initial exemplar, Orange County. So we worked with our colleagues at UC Irvine, headed by, the team was headed by Susan Wang. The UC Irvine team was headed by Susan Wang over there, a good longtime collaborator and friend. And Orange County was a good exemplar because it's the 6th largest county in the United States, has a very diverse population, has lots of hospitals and nursing homes, and it's relatively enclosed. So you basically have ocean to the west, forest to the east, undeveloped land to the south, and what I think is the biggest barrier, traffic to the north. So it's quite enclosed. So you can actually have this kind of natural environment to study different things. So what we did was we first represented what are the connections between each of the healthcare facilities in terms of patient sharing. So this, again, this emphasizes that hospitals, just like people, are not isolated islands. They're actually actively sharing patients amongst each other. So if you think about it, a patient can be shared between 2 healthcare facilities both directly. So I discharge, so if I'm a hospital A, I discharge a patient to hospital B, I'm essentially sharing this patient. Or if I'm hospital A and I discharge the patient to the community and he or she stays there for 30 days or 60 days and ultimately gets readmitted to another hospital, in many ways we are indirectly sharing the patient. So if that patient, for instance, got colonized with MRSA or some type of bacteria in my facility and then goes to another facility eventually, that can spread the infection or spread the antibiotic-resistant bacteria to that facility as well. So all these different facilities are connected with each other. And this sociogram, which is a social network diagram, represents each of the different facilities in Orange County. So each of these green dots are hospitals, and the size of the dots is proportional to the bed size or the number of admissions that the hospital has. Each of these orange dots are LTACs, long-term acute care facilities, and each of these triangles are nursing homes. Again, the size of these shapes are proportional to the size of the facility. And then each of these lines or edges between each of these facilities is drawn if patients were shared between the facilities over the course of a year. So this shows that there's quite a few different connections. Some of these facilities are more connected than others. So think of these facilities as people. So there's some facilities that are more popular than other facilities. So essentially, they serve as nexi, or nexuses, I don't know what the plural of nexus is, of infection control. So both infection control as well as spreading different types of infections. We originally developed sociograms of the, Orange County that were geospatially explicit, but we had agreements with each of the facilities that we wouldn't share their identity. So this is mixed up. This is not a geospatially explicit sociogram, but we have those, of course, if need be. So with this, we can explore the impact of different healthcare-associated infection control measures. So we've worked with the CDC, Orange County Health Department, and California Department of Health. And so one example of this work was also published in Health Affairs, which showed that if hospitals actually cooperate or work together, they can achieve better infection control than working separately, because there are synergies. So if multiple hospitals are actually implementing different types of prevention and control measures, you'll see more benefit than if you just sum their effects. So let me, oops. So we're missing some slides there, but let me summarize. So for instance, our results showed that if, for instance, all of the facilities besides, or maybe just some of the facilities besides a given hospital implements infection control measures, that hospital actually benefits from the other facilities implementing control measures. So that's essentially a free rider effect. On the flip side, if your hospital, you implement infection control measures, you can actually benefit from the fact that other facilities are implementing as well. So you have additional gains beyond your individual hospital. So synergies and free rider effects are important. A lot of the results from our subsequent work were highlighted in the this past September's Vital Signs, and also a press conference that Tom Frieden gave, showing that there's a need for more regional approaches to infection control. So that's examples of our Raya work. The third example is our Hermes work. So again, we had to come up with a name before we actually do the project. So the vision of Hermes was to create this freely available and user-friendly software tool for decision makers to generate this interactive simulation model of any supply chain. So I don't know how many of you are familiar with the term supply chains, but that essentially represents the series of people and locations, activities, equipment, vehicles that help get something from its point of origin to the people. So if you're talking about vaccines, vaccine manufacturers produce the vaccines, and then they have to ship them to different intermediaries, which eventually get to the countries, and the countries get the vaccines out to all the different people. So vaccines, of course, don't naturally sort of teleport to where they're supposed to get. So you can have the best vaccine or the best health product or great food or what have you, but if it doesn't get to the people, it can't help anyone. So that's why distribution is a very, very important part of any public health intervention. And this is one of the things that, for instance, the International Vaccine Access Center, IVAC, focuses on. How do you actually get the vaccines to the people, and how do you get them to actually accept the vaccines? So what we did is we developed this software platform called Hermes, which can get data on any type of supply chain, and you feed it into Hermes, and you can generate this discrete event simulation model, which then serves as a virtual laboratory to guide data collection, identify, evaluate different options, and test different strategies. So this is a visualization of the country of Benin vaccine supply chain. You essentially have Benin here, and then you have actually, this might be Mozambique, so sorry, it's mislabeled. But each of these different locations are different locations in the supply chain. So you essentially have a central store, which then sends the different vaccines to each of the different locations. Each of these columns represents the inventory of that location at a given day. So as these columns go up and down, the inventory is fluctuating because vaccines are coming into the location and they're being shipped out. And every time you see this line that appears between the locations, that's a shipment that's occurring. So essentially something like Hermes can represent what happens if you introduce new products, new technologies. If it can help evaluate different delivery systems. It can determine the characteristics of products and other technologies. Evaluate what happens if you change the configuration and operations of the supply chain. What happens under differing conditions and circumstances. How to best invest and allocate resources, and how do you optimize delivery. This is just an example of some of our global work. We've built models of Niger, Thailand, Vietnam, Senegal. Here are all the different countries and many of the different partners that we've worked with. And one example of a recent study is we used our model of Mozambique and some other countries to evaluate the potential impact of using drones. So drones, as you know, are these unpersoned aerial vehicles that can transport things from one location to another. What would happen if you use these drones to transport things like vaccines? And we simulated that, and we found that it can actually provide cost savings as well as improve the delivery of vaccines. And we're also developing a graphical user interface so that ultimately countries or officials within countries can use the model directly to test different types of scenarios. And this is an example of how we've used Hermes to help the country of Benin address its vaccine supply chain. So back in 2011, they knew that they had to face a number of different new vaccine introductions, and they're wondering if their supply chains could handle these new vaccine introductions. So then we worked with them, as well as the WHO and AMP, to test different types of scenarios, where looking at, okay, what happens if you maintain the same type of vaccine supply chain versus different types of redesign options. So ultimately, we ran different scenarios and we identified a redesign option that actually would provide cost savings and also improve the operations of the supply chain. And they have subsequently been implementing those design changes. So this is just an example of how computational modeling can affect countrywide decision making. Okay, so that's the whole preamble. Basically, that's examples of work in communicable diseases. As I mentioned, within public health and within medicine, computational modeling made its first inroads in communicable diseases because in many cases there wasn't an alternative. In many cases, you don't want to study the spread of infectious diseases because that would be problematic. You don't want to study the spread in a natural setting. That would be problematic. Of course, it's good to study infectious diseases in general. But communicable diseases is a whole frontier where there's been some inroads in terms of the use of computational modeling, but it's really in its nascent stages. So we've seen examples of mathematical models, some good work from different research groups throughout the world, helping understand some of the conceptual underpinnings behind the spread, the development, the evolution of different types of non-communicable diseases. But in terms of impacting decision making, there's a whole broad frontier that's untread. And there's a huge opportunity to really address many important non-communicable diseases out there that can't really be fully addressed by other existing methods. So I wanted to go through some of Virtual Baltimore work. This has been, and I want to emphasize that whatever I'm presenting here is the result of a fabulous team of researchers, analysts, and different folks. So this is all represents the results of our teamwork. So why build a Virtual Baltimore? When I say Virtual Baltimore, if you think of the computer game SimCity, if you're familiar with SimCity or the other types of sim software or computer games, this is similar, except it's Sim Baltimore or Sim fill in the blank. So we've actually built these computer models, or have been building these computer models of multiple cities. But of course, since we're based in Baltimore, and Baltimore is a very key city for many different reasons, I'm going to talk about our Virtual Baltimore work. So why a Virtual Baltimore? Well, first of all, Baltimore, as many of you imagine, is a complex system. There are many different moving parts. They're interacting with each other. Every day when you wake up and you go out into Baltimore, you can see there's transportation, there's businesses, there's food stores, there's recreation areas, there are people all over the place. It's very complex. There are also many different stakeholders. So if you want to implement some type of public health intervention, it's rare where you don't really need to get buy-in with anyone. You can just implement it and there's no problem. So you have to interface with different businesses, you have to interface with the government, you have to interface with all these different stakeholders. So part of it is getting everyone on the same page to cooperate and also to agree and understand that there are win-win situations. Third of all, any type of public health intervention requires some degree of short, medium, and long-term investment and benefits. The trouble with the challenge, and I don't want to say trouble, the challenge with many public health interventions is it requires an upfront investment of time, effort, and money, and many of the benefits occur not immediately, but over time. And if you look at it, many of these benefits ultimately outweigh the initial investments, but those aren't always obvious. So again, it's a complex system, so it helps to have a virtual laboratory to really understand and demonstrate what happens. And finally, stakes are very high. When you talk about public health and medicine, there isn't an area or arena where the stakes are higher. Because essentially, you can't do anything without health. You can't do anything without life. That's why all the work that all of you are doing within public health is so valuable. So if you make a wrong turn or make a wrong decision, the impact could be considerable. And not just considerable immediately, over many, many different years and generations. So you want to make the right decisions. So that's why we feel that a virtual Baltimore would be helpful. So we started off, since we were at the Global Obesity Prevention Center, tackling obesity. Emphasize that this is one of our initial ventures, but I also will talk about how this can be applicable to many other types of diseases and public health issues. So as all of you probably know, obesity involves complex systems. Essentially, there are many biological factors and relationships that affect obesity, ranging from your metabolism to potentially the microbiome. So we're seeing all these this news and these studies coming out showing us that metabolism is a lot more complicated than we first imagined. But beyond that, there's individual behaviors. So what we eat, when we eat, how we eat it, our sleep, our physical activity, whether we commute, all these different things affect obesity. But then there's also the social networks. So we're very much influenced by peer pressure, naturally. We're influenced by our family, our coworkers, our peers, and even people on the street, as well as what we see in Hollywood and on advertisements. There are environmental factors like the food and physical activity environments. So for example, Joel Gilson within our GOPC is doing great work really looking at the food environments within Baltimore and how that really affects individual behavior. There's policy, economics, what's affordable really affects people's behaviors. Many of us have probably heard that healthy lifestyles in some cases can be more expensive than unhealthy lifestyles, and culture, and many other things. Again, this is not meant to be exhaustive. It's meant to emphasize that we're really dealing with complex systems. So our project is titled VPOP, for Virtual Population for Obesity Prevention. It's basically a sim city for obesity prevention. This is sort of play on the word K-pop. But essentially what we did is we developed this, we've been developing this representation of Baltimore. And each person within Baltimore is represented by a virtual person or a computational agent. So for instance, this might be agent number 241205. We'll call him, give him a name, give him whatever name or her, whatever name you like. It has a gender, an age, a height or weight. And it's also an embedded metabolic model. So just like a real person, this has a metabolic model that represents the physiology and metabolism and what happens to calories ingested and calories burned and how that ultimately affects weight loss and gain. And the initial version of the metabolic model was developed by Kevin Hall, who's at the NIH. So essentially you have these virtual people with virtual bodies and virtual physiologies within them, and they're running around doing these different daily activities. So each agent within the virtual Baltimore will wake up, choose whether he or she wants to eat breakfast, and if he or she chooses that breakfast, should breakfast come at home or school, and then if the agent is a student, then the agent travels to school, and the agent makes a decision, okay, should I ride the bus or should I walk to school, and that has caloric implications. So if the agent walks to school, that agent burns the amount of calories based on the distance and how fast and the agent's physiology. And then there's snacking episodes and lunch episodes and all these different things. And there can be physical activity, choosing to go out, moving about town. So imagine many of these different agents moving amongst different food sources, moving amongst different physical activity locations. Okay, so let me show you a visualization of our Virtual Baltimore laboratories. So this works. So you can see the person is moving the cursor, and you can zoom in and out of Baltimore. So this is zooming way out and even further out. Okay, hopefully we won't get to the Earth level. Okay, let's zoom back into downtown Baltimore. So that looks familiar to most of you. So you can see all these different locations that have been marked. They're geospatially explicit. So we're not representing in the visualization every location, but every location's key location is represented in the model. So for instance, that's a park over there. And then we're going to move to some of the food sources. Okay, so let's add some of the kids. So we're not representing everyone. The model represents everyone, but we're just showing the visualizations to some of the people. So these, all objects that are moving around that unfortunately look a little like donuts represent different kids moving around the neighborhoods. So the blue ones represent boys, the red ones represent girls. And each of these agents has a specific age, a gender, socioeconomic status, different characteristics. So they're moving to their different daily activities, and they might stop along to stop at some of the markets or the grocery stores or the corner stores, depending on their different behaviors, and then they might take a meal or a snack or what have you. So throughout the course of the day, they make all these actions, they exhibit all these actions, and then their actions then determine what they eat, how much calories they ingest, and how many calories they burn. And over time, each of these agents can then gain or lose weight. And we also have put in growth curves, so these agents will gain weight and gain height based on their growing, but we can also measure follow what happens to their BMI over time. So, and then further along, if we run the simulation over many years, we can see what happens ultimately to their health outcomes. So in developing this model and also running different types of experiments, we've been working with many different decision makers within Baltimore. So Joel Gittleson and Kara Shipley have been instrumental in forming this Baltimore Policy Working Group, which basically consists of many different types of decision makers within Baltimore. So these are some examples here, but they're basically people who represent all the different sectors and professions that are relevant to obesity, so food and diet and physical activity. City council members, wholesalers, retailers, members from academia, et cetera. So we've been working with different members of this policy working group to help develop the model so it's relevant to decision making, and it includes the key assumptions that they feel are reasonable. And also, we've been working with them closely to determine what types of simulation experiments we'll run. So let me give you a couple examples. So one example of, and this was, we used an earlier iteration or version of our simulation model to evaluate this, is the 2014 Farm Bill. So Council Member Pete Welch was interested in introducing this bill, which would provide tax credits, significant tax credits to anyone who owns a vacant lot in Baltimore and converts that vacant lot to an urban farm. So if they're growing and selling fruits and vegetables. So there was interest with Councilmember Wells as well as other members of city government to determine, what's the potential impact of passing this bill and policy. So this can potentially serve to communicate the benefits of this policy. If you think about it, how else can you demonstrate this? Well, you can do a natural experiment, but that could take years to really see what might happen. And it also could take a considerable time and effort and resources. So we ran these GOPC ran different simulation experiments. And then, as I mentioned, this was sponsored by Councilmember Pete Welch, and this is the tax credit. And then this is Joel Gittleson. This is the back of him. And he's providing a testimony at a public hearing, and he presented, as part of his testimony, presented some of these results. Here's a policy brief that was generated from this, and ultimately the bill passed. So certainly there were other considerations in passing the bill, but we felt that this provided additional scientific evidence that helped support the bill. Another example is something that's currently under consideration is the sugar-sweetened beverage warning labels in Baltimore. So most of you are familiar, there's been a lot of controversy around sugar-sweetened beverages and how much they're actually contributing to the obesity epidemic, and in particular the childhood obesity epidemic. There's been recent high-profile legislation in Berkeley, as well as now recently in San Francisco, Philadelphia, Oakland, and I believe Albany and Illinois, in which they've passed sugar-sweetened beverage taxes. So another policy that's under consideration in different cities is posting these sugar-sweetened beverage labels, warning labels, in places that sell sodas and other types of SSBs, telling them of how the link between SSB consumption potentially and weight gain and obesity. So Baltimore city government was interested in determining, okay, what's the potential impact of this? So we used our Virtual Baltimore model to examine this, and here are some of the results. So this shows what happens if you've, maybe I can flip to this slide first. Oh, I'm actually missing a slide there. But basically, this is overall warning label efficacy, literacy rate, corner store compliance, warning label efficacy for low socioeconomic status individuals, and supermarket compliance with these things. So this allows us to explore the impact of ranging all these different parameters and what's the impact on changes in obesity prevalence. And this shows along this x-axis, the change in obesity prevalence. So you can see this is 0%, so this is no change. This is anything to the right of this is positive change, which is not good. And then anything to the left of this is negative change, which is positive for society. So in the baseline case where you have an 8% warning label efficacy, by warning label efficacy I mean you put a warning label there and 8%, people are 8% less likely to purchase a soda or sugar sweetened beverage. And we use that baseline based on some existing studies, including one that was conducted by Sarah Bleiss, who was formerly a member of our GOPC and Health Policy Management here at Johns Hopkins. And we showed that there's a positive impact on obesity prevalence over time. And we showed that this is fairly robust over many different types of warning label efficacy. You actually have to go fairly low, well below 4% for it to not have an effect. And the literacy rate, even if you get down to a 51% literacy rate, this still has a positive effect. Corner store compliance still has a positive, when I say positive effect, means negative effect on obesity prevalence. Same thing with changing the label efficacy amongst low socioeconomic status populations, as well as changing supermarket compliance. So we found under many different situations that instituting the SSB warning label can have a positive effect. Again, positive for society, negative on obesity prevalence. So we've also used our Virtual Baltimore to run many other different experiments looking at the impact of improving physical activity among kids, trying to quantify that impact, like what happens, what's the impact on costs, what's the impact on future disease outcomes, and all those different things. So this is just the edge of the frontier. So certainly we've been using it to address many different obesity-related issues, and obesity is a major problem, but there are other major health problems as well. So I've highlighted some of the other pillars of the Bloomberg American Health Initiative. As many of you are aware, that's a generous gift from Bloomberg Philanthropies, and there's a new effort that's headed by Josh Sharfstein, who's the associate dean here. And this is really to address some of the major issues that are facing American health. And some of these other issues besides, so obesity is one of the 5 pillars, obesity and food systems, but the other pillars are drug addiction, violence, adolescent health, environmental threats. And so we can really use a virtual Baltimore or virtual New York City or other cities to test many different types of policies and interventions that are related to these different public health threats. So for instance, drug addiction, what's the impact of introducing new treatment centers in different locations? What's the impact of changing different policies that might affect access to treatments as well as access to different types of drugs? Or violence, what are the high crime areas? Where should you place violence prevention programs? How do you address domestic violence? What's the impact of different types of behavior changes? Adolescent health, similarly. There are many different adolescent health issues. You can simulate those, not just the prevention and interventions, but also you can simulate what's the impact over many different years and generations. And environmental threats. So environmental threats are major, broad impact problems that affect large percentages of the population. We can demonstrate how the impact can go way beyond where the immediate environmental impact is and how that might extend over time. So certainly we'd be happy to discuss other possibilities, but this is a new arena where we really can simulate these different types of problems, simulate some of the possible solutions, and really generate a lot more evidence and also communicate some of these issues. My apologies, the slides are a little out of order, but this basically shows how we simulate the impact of increasing physical activity among youth. And this just basically shows the impact of increasing physical activity so that youths meet these different recommended guidelines, like active at healthy level, how many fewer overweight and obese youth there will be, how many medical costs may be averted, how many productivity losses may be averted, how many years of life may be saved. And this is looking at other types of recommendation levels, the CDC level as well. So we did that work as part of the Aspen Institute's Project Plague. So I just want to give a quick plug for our GOPC. We're a university-wide center. We're headquartered at the Bloomberg School of Public Health, but we include faculty, staff, and students from many different schools and departments. And we have an administrative core, a system science core that does a lot of these computational techniques and approaches and models. We have an education training program. We have multiple domestic and international efforts. And here's a collage of many of our members. Again, this is not exhaustive, but I want to highlight some of our members. Cheryl Sigmund, our center manager, she's really basically heart and soul for center, has been keeping everything going. I mentioned Joel Gittleson, Sarah Roberts, a communications specialist. Sean Brown is Director of Public Health Application at the Pittsburgh Supercomputing Center and has been really central to many of our efforts. Daniel Hertenstein and Marie Ferguson have been really pushing forward our modeling efforts, as well as Marie Spiker. I'm forgetting a lot of people, but these are some of our key members that have really been pushing forward our computational simulation modeling efforts. So with that, I'd like to thank you for your time and attention. We'd be happy to address any questions.
Let me just ask the first question. So when you say these agents in Baltimore, are those characteristics assigned on actual individual census data or on average for say a zip code or something?
So it's meant to recreate what's actually happening, what's the actual individuals. Now there's going to be some degree of error because you're essentially the census reports data in terms of, okay, in this census tract, this is the gender distribution, this is the age distribution, et cetera. The census, of course, does not have identifiable data. The files that are available doesn't have identifiable data. So the process involves trying to recreate the population by fitting these different characteristics and trying to recreate the same type of distributions.
Right, okay.
So it's iterative proportional fitting. It's similar, it's not exact, but it's pretty close.
Yep, I see. Okay, great. And so I should have said it's a great talk, and it's really it's wonderful to see the broad range, and I can think of lots of applications for this for thinking about policies and whatnot. So if you talk about much of public health starts with infectious disease, you use the infectious disease example in vaccines. Can you give us an example from either infectious disease or another field where using these techniques have made a profound change in the way interventions are carried out or policy?
So one example that I mentioned is with the vaccine distribution or supply chain work. So what that's done is it's addressed many different, there's been a number of different countries where we've built these models and helped them address key questions such as, should we introduce certain new vaccines? Are we ready? Or should we actually change the supply chain or redesign the supply chain? So a lot of those changes have been enacted. But another thing that's actually done is it's brought a lot more attention to the issue or problem. So a lot of the focus on vaccines prior to 2011 or so was more on developing new vaccines and also making these vaccines affordable to countries. So that's why Gavi was developed, and the Gates Foundation did great work in spearheading a lot of that. But it wasn't until later that decade where there was a slow realization that, well, these vaccines aren't actually getting to the people. And through our work with the Gates Foundation, we demonstrated, well, this is really important. And then that trickled down to Gavi, WHO, UNICEF, and all these different major organizations as well as countries to realize, okay, we need to really address this. And as a result, you've seen a profound change in terms of the importance of this issue. So that's an example of country level changes, but also global changes as well.
Great, thank you. So we have a few minutes, so I think, is there a microphone over there too? Do you have a mic? There's only one. Okay, let me go on. We'll go first to you.
Hi, my name's Emily. I'm an MS-PH student studying human nutrition here at Hopkins. So I have two questions. No, thanks. So first of all, how many years will it take for tools like Virtual Baltimore to become widely available to the point where, say, communicable disease models are now? And the second question is, how do you and your team plan to assess the relative accuracy of the simulations you run?
Okay, good question. So I'll answer the second question first. So there's a process or a general set of processes called validation, so validating a model. And there's different levels of validation. So the first level of validation is face validity. So face validity is simply showing to people who are familiar with a system or familiar with a situation and asking them, does this make sense? So it has to pass face validity first. You show the policymakers, decision makers, and say, okay, are we representing things accurately, et cetera. Of course, if something doesn't pass face validity, you really have to go back to the drawing board. Okay, the next step is criterion validation, which basically means how well can the model reproduce different types of data, different types of trends. So we take retrospective data or prospective data or any type of data, and we try to recreate those. And it's not just you try to do this in all different types of directions. So for instance, if you're building a Virtual Baltimore, you don't want to just try to recreate, okay, what are the disease outcomes? You want to try to recreate, okay, are people actually moving to where they're supposed to be moving? So for instance, we looked at data that was drawn from Joel Gildeson's BHCK, or Be More Healthy Communities for Kids, data on where people actually go and say, are we reproducing the agent or the children's movements. So we keep doing those type. And validation, I want to emphasize, is not something that stops. It basically continues. So you try to gather as much evidence as possible that supports the fact that you are representing what you're supposed to or trying to represent. Of course, it's a model. There's going to be some assumptions, so it's not going to completely replicate real life, but we want to get as close as possible. There are other types of validation. There's convergence validation, so you have different types of models and you see if they generate the same results where they're supposed to generate the same results. And there's also divergence validation, where if models differ in different ways, are they producing different results where they're supposed to produce different results? So that's a constant aspect of modeling. To address your first question, where there's different steps that you have to go through. One is, of course, you develop the model, and then you have to make sure the model's validated, et cetera. So the length of time that takes really depends on what you're trying to model, how complex the situation is. So the fastest we've developed a model was within days, and that was to address some issues within India looking at infection control measures. Of course, those made large assumptions, but their leadership, the Gates Foundation, was very interested in asking some questions, so we developed that fairly quickly. But more complex models, of course, take more time. The second step is making the model digestible by decision makers or the general public or whoever your target audience is. Now, that's a big step, because there's one thing is to develop a model which can be used by people who are in the know and can understand the code. You don't have to worry about like the graphics as much, and you can even have lines of code and it can look ugly, but as long as it does what it's supposed to do. It's a whole different story if you want to develop software that people can actually use. There's all these design issues, there's usability, there's language. You don't want to use all this scientific jargon. You want to have something that people can actually use directly. It's simple and not something that they have to read through all these user manuals to read. To give you an example, when we were in Health and Human Services during the pandemic, many times we would have 5 minutes max, sometimes just 1 minute for a decision maker to come in, and basically you have to capture their attention, and you basically have to cram as much information as possible within a single slide or a single visualization. And one example is we had developed the visualization. One of the assistant secretaries was just not really paying attention to what was being said. And we flashed up a visualization which showed, okay, this is what happens if you do nothing, and this is what happens if you actually do this intervention. And one of them showed all these cases, like it was getting all red, and the other one showed not as many cases. He looked up, he said, okay, give me 10 more minutes. And he basically told everyone, hold my schedule, hold my calls, I want to listen to this a little longer. So those are key things to consider. Communication is a very, very important part of public health and global health. And I see my colleague Lois in the audience who handles policy advocacy and communications. She can wax on for several hours about the importance of communication, but it's very important. So you come up with the greatest ideas, but if you don't communicate to decision makers, it's almost like you don't have those ideas.
So we have a reception afterwards, so there's time to talk to Bruce there. But if anybody has one last burning question, we can take it here, but otherwise we'll go out and get to interact with Bruce one-on-one. Okay, great. Well, Bruce, it's exciting, so we're going to, I guess, we're going to see you virtualize the entire U.S. population, I think, and we'll look forward.
You're all virtual people. Can
we use this for student recruiting?
Exactly, yeah.
But thanks very much, and it's great work. So please join me in thanking Bruce.
Thank you. Thank you, everyone.